Dialysis SS Synergy 2020. I'm the master of the ceremony, Emma Lee. It's my pleasure to welcome you here and show you great appreciation for the participation on the meeting while facing severe coronavirus. And thanks to coronavirus giving such a great chance to try a teleconference with which we haven't tried before. And today is the last day of DASy, so please do not hesitate, take your chance and wave your hand as hard as you can. You are always welcome to ask questions and join the discussion. So, for our first session, talking about innovation in vascular access, now I would like to introduce you our chair, Dr. Ke Boren, Dr. Ke from Taiwan, and our commentators, Dr. Su Shanghao from Taiwan, Dr. Wan Heng from China, Nurse Lilian Lo from Singapore, Dr. Zhu Zhongyu from Taiwan, and Dr. Liu Yangdong from China.
Good morning, ladies and gentlemen, my dearest online audience. Today is our third day of DASy 2020. I'm really happy to be here, and this is quite an interesting session, I believe. And I see our panel is already online. On the right-hand side of me is Dr. Zhu Zhongyu. And we have our distinguished panel as well online, like Jackie Ho, Dr. Tay from Singapore, from China, Liu Yangdong, and from China also Wan Heng, and so on. So now, and our distinguished speakers, innovation is always very, very important during our daily practice. Without those technology, we can't treat our patient. A long time ago, whenever people get a renal failure, nothing we can do. And then we got renal transplantation. Now we got many other good renal replacement therapies, such as chemodialysis, peritoneal dialysis. But, however, during the treatment, a lot of bad things happen. So it's our duty to decrease the complications and the sufferings of our patient during the treatment and give them quality of life. So in the following section, we are going to hear some talks about innovations in dialysis access therapy.
For our first speakers, let's welcome Dr. Feng-Yu Wei from Taiwan, talking about portable device for your HDSS monitoring.
Hello, everybody. It's my pleasure to introduce to you our novel portable device for hemodialysis vascular access monitoring. My name is Yu Wei come from nephrology department in Xinguang Hospital in Taiwan. Hemodialysis vascular access monitoring is an important issue. However, it is easily ignored in every hemodialysis center because doing these things is time-consuming and less profit. In Taiwan, we don't create extra charge for patient to provide this service. Besides, it is unable to self-detect as a thermometer. During the hemodialysis room, it can be widely used maneuver to measure in our hemodialysis section for our dialysis patient. Here is our study published in 2017 in BNJ Open. We try to identify the importance of vascular access in hemodialysis patients related to their short-term and long-term mortality. Because in our hospital, we routinely measure our dialysis patients' vascular blood flow every 3 months. We have done it for more than 20 years. So we have plenty of data to support this study. And we find when the access flow below 500, it is sharply related to the mortality when compared to other groups of blood flow. So that means when the access flow is decreased, it closely related to the mortality in our patient. So as from the perspective of patient care, it is an important and crucial issue. In our Taiwan, we have almost 80% hemodialysis patient among the end-stage renal disease groups. However, the 80% rate of AV fistula failure in Taiwan, if we translate this percentage to real-world data, in Taiwan we are more than 80,000 end-stage renal disease patients receiving dialysis, and 80% for hemodialysis. So we approximately have 67,000 patients receiving hemodialysis. That means we have 107 event rate of AV fistula failure to need the thrombosis therapy or to receive the surgical intervention for stenosis. We know we have many kind of choice for vascular access. In Taiwan, most of our patient choice AV fistula. It is according to the guideline, the most durable and the most consistent use of fistula have better care quality than other vascular. However, the importance is using this kind of treatment during hemodialysis session need monitoring, surveillance, and somewhat diagnosis test. The monitoring means physical examination to detect pathological physical sign. The surveillance use the periodical evaluation by means of test. That means use the transonic machine or use the blood flow assessment. That kind of can quantify this blood flow translate into the data. And the diagnostics mostly means the image to assess the abnormality of the vascular. However, it really requires experience. Here are some signs of vascular dysfunction when during the dialysis section, the clinical suspicion should highlight to the vascular dysfunction. The first one is access extremity edema, and the second one is post-venipuncture, prolonged bleeding time. The third is the conversion of portable serial to pulse. When the portable serial to the pulse, it means the blood flow may below 500. Besides, by listening, we can identify the bruits. It means high pitch. High pitch means the occurrence of stenosis. During the dialysis section, elevated negative arterial pre-pump pressure also suggests the arterial inflow stenosis occurs in this. So, what's the difficulty? If we have many experience and many technique, the difficulties, that means equal to the why we need surveillance. We have three reasons for doing this. The first one is experience. We know experienced nurse or technician or physician have different idea of this vascular dysfunction. Besides, the quantity of the experience measurement or physical examination, it cannot be quantified. The third one is kind of physical examination cannot related to the patient's outcome. So we need more accurate machine, more accurate maneuver to identify the real blood. Mostly we use the transonic HDO3 to assess the blood flow. When the blood flow of the AV fistula below 500 or AV graft below 600 and the assess flow reduction over 25% in the past 4 months, it may refer to the vascular surgeon to create new shunt or to revision their AV fistula. But what is the next? It's our majority of this talk. It is a portable device to identify the patency and the efficacy of vascular access. Besides, it can upload the data to the cloud to share with the physician and the nurse in the hemodialysis. That means PPG, photoplethysmography sensor to measuring blood flow at AV fistula. It's Professor Zhao's invention in National Jiaoda University. What is PPG? It is a kind of a technique to using the light to sense the flow in our tissue. So it is a non-invasive measuring method to to use the fixed wavelength light in the living tissue. So it has a sensor to sense the change of the reflection by optical emitter, and they translate this kind of reflection into some kind of wave change. So using the measurement, they can identify the blood flow change by using this. This is the implantation. Using this sensor probe on AV fistula can sense the change of blood flow and can calculate the blood flow change and measuring blood flow using the artificial neural net model to self-learning the change of the calculation. So we use this kind of machine to conduct a study in Xinguang Hospital and compare with the golden standard transonic HD03. Patient not allowed to talk during the measurement. And that is the real picture when we do this study. We open this machine and the charging, and we key in several data to measure before and detect using this sensor on patient's AV fistula, and this arterial side to measurement, and we can it is a before measurement, the stable wave show up in the morning. There are some case report. The case 1 is 70-year-old female, hemodialysis for 4 years. The diversity of the HD03 because due to different weight of needle puncture. In this way, the HD is over 2,000, but this way it is 1,040. However, our PPG reveal the real data in this, so it can correct the data of HD Linsan due to their pitfall of different weight of the needle puncture. The second one is a 65-year-old male. He have a diverse vessel, so during the section they can measure HD03. However, our PPG data is consistent. It is not interfered by this diverse. Here is our unpublished data. We using this HD Linsan, HD03 and the PPG have a strong association. Here is some comparison of the traditional device to measure our patient's access flow. I think it is easily used and wireless and inexpensive. Besides, patient can self-detect in their home. So our conclusion is new arterial neural network can accurately measurement of AV fistula by PPG sensor, and we think it can bring some light for our hemodialysis patient to improve their quality, control, care of their vascular access. Thank you for your attention.
Well, Dr. Fan has introduced us a portable device, non-invasively can measure the blood flow of our AV axis with the input of blood pressure data of the patient as well as the saturation of the patient, plus a device, just a tiny device, portable, to do the measurement. Then it can replace or correlate to the transonic measurement of the blood flow. Then we can do our surveillance and do the further treatment for the patient. So I think we can have some discussion on this device presented by Dr. Fan, our panelist. How do you think about the device? Is it useful in your daily practice? Actually, for surveillance, we have learned that in new guideline, the surveillance is not as important, even if we put it in the second line compared to the monitor itself. But still, I think probably those kind of devices are quite helpful. Jackie?
Yes, very nice to see this portable device that can do the test maybe every time before the patient go for dialysis. I have a very quick question. Is this more on monitoring the actual volume, or it's more on the trend of the results? And I think later on, I also hope that maybe Milind, who is director of the FMC, he is actually looking after a lot of patients over there, and maybe he can also comment on that later on. Thank you.
Yeah, definitely. We want the opinion from someone who take care of the dialysis every day. As far as I know, the device, a portable device, it can measure every time the blood flow of the axis, and they had done studies correlated to transonic machine numbers, and they found a quite high correlation with that. So any other commentators want to comment on this?
Yeah, good morning, everyone, and thanks, Jackie. Couple of points. This would, of course, be very, very helpful in the dialysis setup, and I have to look after a large volume of patients. And if we can have some device like this, that will be quite helpful. It will be nice also to correlate it with clinical outcomes, because there has been a lot of controversy based on volume flow measurements for correlating with outcomes. So if it can correlate with thrombosis or even need for interventions and time of course, the time to intervention, or most importantly, is the life of AV fistula or AVG, that will be quite nice. But of course, that research will take time. We also have a similar project in Singapore, which I run with some of my colleagues, and we have used similar approach. So I think maybe it is also time for us to join hands together and work on this. I was supposed to be in Taiwan and would have been very nice to meet Dr. Liu, but I'll reach out separately.
Well, so you have mentioned that you have similar project in Singapore. So during what step, or how is the gadget? Is it built? Is it in clinical use or still in very infant age?
I cannot say too much because of proprietary reasons in public forum, but it is similar, but there are a few more sensors available. We have also focused on volume flow measurements, but also more on the trend part. It is, I would say it is 80% built. So we still need a little bit more clinical data. So, but I think instead of competing, we should collaborate.
So definitely that kind of gadget, they measure the numbers and then hook up to the internet and do some calculation, and they can help our clinical judgment.
Yeah, I mean, that, and plus we should also not ignore that there's a lot of real-time data that comes from dialysis procedure, which is 3 times a day. So it is a, I will talk about big data in a moment, but it's a time of big data, and to ignore any data would be not ideal in this day and age. So, each dialysis session 3 times a week generates high volume of data that needs to be incorporated.
So we should proceed to the next talk.
Yeah, thank you.
For our next speaker, Let's welcome Dr. Tan Chie Suai from Singapore, sharing about report on first clinical trial of using Sirolimus coated balloon for HDSS stenosis.
Thank you for the invitation to share with you on the use of Sirolimus coated balloon in the salvage of thrombosed arteriovenous graft. First, I would like to apologize for not being able to be in Taipei to share with you on this topic. As in Singapore, we are fighting the COVID-19 outbreak, and I hope that the situation will get better over the next few months. A functioning access is critical to the delivery of life-saving hemodialysis therapy in patients with end-stage renal disease. Arteriovenous grafts are created in patients who have poor veins or are poor candidates for arteriovenous fistula creation. However, neointimal hyperplasia often occur at the graft-vein junction, resulting in narrowing of the vessel, poor flow within the graft, and ultimately thrombosis. Although we are able to successfully salvage thrombosed arteriovenous graft either through open or endovascular technique, the patency rate after successful salvage therapy remains poor. Based on the literature, the average 3 and 6 month patency rate post-salvage are 49 and 38% respectively. This prompted the Society of Interventional Radiology to recommend a target patency rate of 44% at 3 months and 31% at 6 months. In our center, our patency rate were close to the recommended target patency rate. However, if we examine the figure closely, it still meant that up to half of the patients who had undergone successful salvage therapy would be back again within 3 months. In our center, we attempted to improve the outcome by applying Paclitaxel coated balloon for patients who present within 3 months of their prior intervention. But as you can see here, the effect was not great, and only 43.6% remained patent at 3 months. Therefore, besides looking at the technical success rate, we should also focus on improving the functional longevity of the AVG after successful salvage therapy. Sirolimus coated balloon has been successfully used in coronary artery intervention by preventing intimal hyperplasia associated with balloon angioplasty. Compared to Paclitaxel, which is the current drug used in drug-coated balloon for peripheral intervention, Sirolimus is cytostatic in its mode of action. Moreover, it has a huge margin of safety compared to Paclitaxel. We therefore postulate that the application of Sirolimus coated balloon at the graft-vein junction after successful endovascular thrombectomy will minimize neointimal hyperplasia and thereby improve the patency of the AVG. In terms of sample size, we took into consideration the suggested 3-month primary patency rate of 44% by the Society of Interventional Radiology. If we assume that Sirolimus coated balloon will improve the 3-month patency rate to 75%, a sample size of at least 19 is required to show the significant improvement from baselines. Hence, we carried out a single-center prospective study of 20 patients who presented with thrombosed AVG. Sirolimus coated balloon is applied at the graft-vein junction after successful endovascular salvage, and the patients were followed up at 3 and 6 months with duplex ultrasonography. These were the primary and secondary endpoint. The primary endpoint was set as the primary patency rate of the AVG at 3 months, and the secondary endpoints were the patency rate at 6 months and the number of interventions needed to maintain the patency during the study period. These were the inclusion and exclusion criteria. Essentially, we only look at thrombosed AVG in the upper limb, and patients with central vein stenosis or stented graft vein junctions were excluded from the study. A total of 37 patients were screened and 20 patients were recruited over a 1-year period. The last patient was recruited in September 2019 and just completed the 6-month follow-up. Majority of the screening failure were due to the presence of coexisting central vein stenosis. Others were due to the presence of residual thrombus or had failed endovascular salvage of their thrombosed AVG. These are the baseline demographic data of the 20 patients that were recruited. The median age was 68 with a predominant female population. Majority of the patients are diabetic and up to 50% were on antiplatelet therapy prior to intervention. The median vintage of the AVG was 14.5 months and were predominantly in the upper arm. About a third of these patients had 1 to 2 interventions in the preceding 12 months. TPA was the thrombolytic agent used in 2/3 of the cases. 7 mm high pressure balloon was the predominant balloon size used to treat the culprit lesion, and cutting balloon had to be used in 20% of the patient. The size of the Sirolimus balloon used ranges from 7 to 8 mm. Most significantly, none of the patient has any significant residual stenosis or thrombus after the procedure. These are our results. The primary patency rate at 3 months was 76.4%, with 3 patients experiencing rethrombosis within 90 days and 1 had repeated angioplasty performed for low flow in the AVG. 3 patients had complications before reaching the 3-month endpoint. The complications were all unrelated to the use of Sirolimus coated balloon. 1 had surgical revision of the A limb of the AVG for pseudoaneurysm formation 8 days after successful thrombolysis. 1 patient passed away from intracranial hemorrhage, and 1 had explant of the AVG at 88 days. Significantly, these 3 AVGs were all patent at the time of the event. The primary patency rate at 6 months was 64.7%, as 2 patients had rethrombosis of their excess at 134 and 157 days post-intervention. This is how the Kaplan-meier curve looks like. The estimated median primary patency is 381 days. The range is pretty big at 138 days. This is one of our first few patients who was recruited in the study in 2018. Post-thrombolysis, the graft vein junction was treated with the Sirolimus coated balloon. This is how the graft vein junction looks like on DSA. And this is how the graft looks like 13 months after treatment with Sirolimus. Significantly, the patient did not require any interventions within the 13 months interval. From our study, it will appear that treatment with Sirolimus coated balloon at the graft vein junction after successful salvage of thrombosed AVG appears to be safe, and the primary patency rate at 3 and 6 months appear to be superior when compared to plain balloon angioplasty. The limitation of our study include a small number of patients recruited and the possibility of selection bias. Moreover, aggressive treatment with high pressure and cutting balloons were required to manage the acute recoil of the graft vein junction, which may not be the situation in the real world, where stenting of the graft vein junction is often used to manage the acute recoil. Nevertheless, within the limit of our studies, we have demonstrated the feasibility of using Sirolimus coated balloon after successful endovascular salvage to improve the 3 and 6 month primary patency of the circuit. Larger randomized controlled studies are required to verify our findings. With that, thank you for your attention.
Thank you. We have learned that Sirolimus, Balloon grappling junction performance. So, Sonia, how do you think about that study?
I see this is interesting, but I think I am more interested about the cutting balloon. Could I identify the result of the cutting balloon? I can't see any result of that, because I think because if you force to injure the vessel, and you can stimulate the inflammation if we give some drug will prohibit. And I understand from the PAD experience, I see some patients use the device. We use the cutting balloon. We use the drug cutting balloon. We see the pseudoaneurysmal dilatation about the target. So I am interested about if you use the cutting balloon in this graft junction, it's work or you will be aneurysmal dilate. Especially this result maybe have 1 year's results. So I ask the speaker, have any experience about that?
For me, myself, I do have two questions in mind. First, we do have Paclitaxel balloons on the market. So why do we need a Sirolimus? And secondly, this study is regarding the artificial graft outlet junction. So does it, can we have a similar performance on regular AV fissure? So may we refer to our panelists to have some comment on this talk?
So there were two questions. Number one was on the use of a cutting balloon. We do have a subgroup of patients who require cutting balloon. The requirement for enrollment will be successful treatment of the graft vein junction after thrombectomy. So we need to treat it such that there is no recoil. In the subgroup, 20% patient who actually do not, who underwent cutting balloon, they have similar performance as compared to the high pressure balloon group. So I do not think it's the cutting balloon that is per se the reason for their longevity, but rather the ability to achieve no residual stenosis as being the goal of treatment. Now, with regards to Paclitaxel versus Sirolimus, as we know, Paclitaxel itself is there's some controversy embroiled in it, especially in the lower limb. And secondly, we do know that majority of the drug is actually lost during transit for Paclitaxel coated balloon. In comparison, Sirolimus coated balloon, the technology is such that it's actually using a nanotechnology, where the balloons are actually sprayed with Sirolimus using a lipophilic molecule. So the transmission of the drug is actually very efficient with no loss of drugs. And the safety margin of Sirolimus is much higher than that of Paclitaxel. And secondly, as a nephrologist, we are very familiar with Sirolimus. I mean, it's one of the drugs that we use in transplant patients. So when they were approaching us to try this out, I said, why not give it a shot? And we are quite surprised with the results. Now, whether this is applicable to arterial venous fistula, we have done a pilot study about 20 patients. The results were very encouraging. We are looking at up to 90% patency rate at 3 months, which we have not shared in this presentation, but that is part of our registry work. So at this point in time, I would say that Sirolimus coated balloon appears to be effective as Paclitaxel coated balloon. However, we are still in the early stages and we are planning to run some randomized controlled trial to verify our findings. Now, as to why we use the graft vein junction, why we choose the AVG, because the prototypic lesion is actually a neointimal hyperplasia. And therefore, if the Sirolimus coated balloon works by inhibiting neointimal hyperplasia, we can actually show and demonstrate the positive outcome. And when this technology came about, we decided to do it in the worst group, which is the AVG, because there is nothing else better in the market. And therefore, we actually chose the thrombosed AVG group to do this pilot study rather than in the fistula group.
Well, thank you. We may discuss on this with other two similar topics later on. And so we are moving to next talk. Next talk will be...
For our next speaker, let's welcome Dr. Milan Nikam from Singapore, talking about application of AI to dialysis and vascular access care.
I think we want to invite some short comment from our panelists. So, yes, please.
Dr. Nikan, many thanks for your excellent presentation. I'm Remy Chen, a nephrologist in Japan. And in Japan, I wanted to share some of my comment because you already answered my questions in your last slide. In Japan, we have more than 4,000 HT centers in Japan, and more than half of the HT centers are treated by non-specialist physicians or surgeons. So many medical treatment plans are just based on only the quality indicators according to the guidelines. So I've always think about this is almost the same to the AI or an automatic analysis system. So my question is, do you think in the future, the regular HD will no longer to need any physician to operate it? But I think your last slide already asked the questions. So,
well, will the artificial intelligence replace the physicians?
Yeah. I'm afraid if we lost, we will lose our work in the future.
Milan,
I am afraid not. Actually, so my job is to actually coordinate care in dialysis across Asia. So I have 22,000 or 33,000 patients if I include Japan. There is no way I can reach out to all these people. Okay. What it will allow us to actually focus on is what matters more, not just KT over V and not just hemoglobin. Because I always say in my value-based care talks that if you want to generate value out of care, you cannot just look at one thing, okay, or two things. Because these solutions will have incremental impact. To actually make a big impact, you need to look at everything, okay? And you can only deliver that when you focus on patient outcomes such as hospitalization, mortality, etc. So what this will allow, for example, you have to look at 4,000 patients. This will allow you to reach to those dialysis patients using those non-experts, yeah? Because I have this particular problem in Indonesia. There are 120 nephrologists in Indonesia for a population of 250 million people, which is kind of the similar number of nephrologists in Singapore, where we have about 6 million people. So, it gives you a scale of the problem. But there is no way we can just reproduce nephrologists in Indonesia who are going to go to and provide that care. But what this will allow us to focus and give some solutions and tools to these physicians who are providing care at the point of the patients.
Very good.
Yeah.
So
I completely agree.
I think we have online questions from our audience who is going to ask, I think, about the drug balloon. May I invite Dr. Tan Chen-Shui, to answer the question. As Chief Intervention Radiologist at SGH, you had a nephrologist, and you have a lot of experience in treating those lesions. And our online audience asks you, how about the efficacy of the drug balloon on lesions with thrombus? Does the drug go through the thrombus and can be effective? And the second question is quite straightforward. For the graft outlet lesions, how to choose the proper size?
Okay, so with regards to the first question, for the drug-coated balloon to be effective, you need to clear the circuit of thrombus. So if there is residual thrombus, there will be no good contact with the vessel wall. So the drug will not be able to transfer effectively from the balloon to the vessel wall. Therefore, first requirement is that you need to complete the procedure as how you do it in a routine care. That means to remove the thrombus to treat the underlying stenosis. What the drug-coated balloon does then is to actually slow down the process of new intimal hyperplasia and therefore improve the patency of your procedure. The challenge in a lot of thrombectomy procedure is that you get good technical success rate, 90% success rate, but this patient will be back again. And a lot of time when they come back, it's because the angioplasty itself induces injury to the vessel wall. And as a result of this injury, the new intimal hyperplasia is started, and therefore it will recur again. And therefore, by adding in the drug-coated balloon at the culprit lesion, we can potentially slow down the entire process. And you can see that in one of the patients, in fact, quite a number of patients, they have intervention-free days after the index procedure, which is very encouraging. Sorry, what was the second question again?
Size. How does size choosing?
Okay, so in our site, we usually use the 6 millimeter graph. Therefore, the minimum size that we need to actually use would be the 6 millimeter. But if you at the graft junction, because of the size graph, the vein, the native vessel graph discrepancy, we generally oversize by either 1 or 2 mm. And therefore, minimum will be at least a 7 mm or the 8 mm to ensure good contact with the native vessel. Because new intimal hyperplasia tend to occur right at the junction. If your balloon is too small, you only treat the graft side without coating the vessel side. And the good thing about this drug-coated balloon is that it's semi-compliant. So it actually molds to the shape of the graft vein junction. Unlike a compliant balloon, which may rupture the graft component, the drug-coated balloons are generally semi-compliant, and therefore, even if you overinflate, it will mold to the shape of the vessel junction. So at the graft side, it will look smaller than the native vein side. So those are the features of the drug-coated balloon that allow us to do that. But I will usually use a 7 mm to ensure good contact at the graft side. Native vein side, if there's size discrepancy, I can go up to 8 mm to ensure good vessel contact.
Thank you very much. Now, I think it's time to proceed to next talk. Next talks about drug balloon as well.
For our next speaker, let's welcome Dr. Xingjun Xian from Taiwan, who is on site with us in Taoyuan, talking about drug coating technology in chronic hemodialysis catheters and its applications.
Good morning, everybody. I'm Dr. Xin from Chang'e Memorial Hospital. Today, I would like to discuss about the drug coating technology in chronic hemodialysis catheter and its applications. First, I have no conflict of interest. As vascular surgeons, we have the catheter last in our belief. However, catheter is lasting in the daily practice. About 80% of the patients initiate their hemodialysis via any catheter, and around 10% of these patients going on using catheters above 3 months after the initiation. Catheters are still has done their roles as vascular access in some clinical situations. The guideline indicate its permanent usage for patients with severe access-induced ischemia, or the patient with severe heart failure and limited life expectancy. And the guideline also indicate their short-term usage with a patient with a PD peritonitis or patient who are waiting for the living donor transplant or the bridging access during the access maturation or during the complication. And last, the recent myocardial infarction within 2 months. There is contraindicated for access creation. So I have to say, catheter design and performance matters. Among these catheters, we prefer the palindrome catheters with the following reason. The first is the symmetric towel tip design. They had a low recirculation rate if reverse connected. To our knowledge, the reverse connection is not uncommon in the HD unit. And the second is the it requires the shortest length within the right entrance, about 2.5 centimeters, compared to other catheter designs that require 4 to 4.3 centimeters within the right entrance. The last is the soft capacitant material is comfortable for patients to bear at. However, there are still something we will not satisfied about. One is also the capacitant material itself. It is too soft for us to push for the pushability during the over-wire exchange. The second is the large side hole that will wash out the large solutions that cause the catheter thrombosis, as shown in the bottom picture. So in the real-world study about the catheter patency, the patent catheter is failed to show the superior impedancy compared to other catheter design. So the manufacturer had provided a new generation heparin coating patent catheter. It contains a non-thrombogenic heparin coating layer and the non-thrombogenic negative charge hydrophilic coating layer. The manufacturer called fully the inner lumen, where the blood goes through, and the outer lumen from the catheter cuff to the tip, which will insert in the body. And the only significant difference tell from the regular one and the heparin coating is only the edge on the blue tip. The manufacturer also conduct the in vitro and the in vivo study, compare the coating catheter with the uncoating catheter. They have the conclusion that the coating, heparin coating catheters have decreased thrombosis and the fibrosis formation rate. There is the single arm study that performed by the team of Michael Tao. They had 60 catheters within 57 patients with a total catheter day about 5,300. The average enduring time of catheter is around 100 days. The result is quite satisfying. Only 6 catheters were exchanged due to the malfunction. There are 6 catheters had to be removed due to the infection episode. There are just only 3 bacteremia events with total count about 0.56 per 1,000 catheter days. There are no patients suffer from the heparin-induced thrombocytopenia. So they have the conclusion in this study, the heparin-coating patented catheter is the safe and reliable way for the chronic dialysis usage. So I would like to share our clinical case at our hospital. This is the case 1 is about a 70-year-old lady. She had multiple access creation and maintenance. Eventually, she had a catheter dependent for months. You can see a lot at the stand over her upper body, and she is relied this static catheter for hemodialysis for months. And she is brought to our clinics due to the catheter obstruction. So we had the over-the-wire exchange simply via the original insertion site. With the vena track devices that provided by the manufacturer. As you can see, the 2 styles that can put into the lumen of the catheter to have a great support. We just put it together and make it very smooth wire exchange. However, the result is not satisfied. We have to patient experience muscle sepsis due to the catheter infection. So we had to remove the catheter 1 month after the implantation. The second case is the 80-year-old female. She had been catheter dependent for years, and you can see the multiple scar on her upper body, and she experienced several times of catheter revision. The last event is the bacteremia episode, so we removed the catheter and set the temporary catheters via the lower body. And before the operation, we performed the ultrasonography and can see a settable diameter over the right internal jugular vein. But we are cautious because she is catheter dependent for years. the possibility of central venous occlusive disease is very high. So we set up angiography sheets and perform the angiography before we set the implantation of the catheter. And we found the very weird angulated wire course during we manipulation with the wire. So we do the angiography, and it shows the total occlusion with much collaterals of the superior vena cava. And finally, we engage with the wire into the right entrance. However, we face a very high resistance over the PA when we pull in the PA away sheath within her body. The patient is agitated at the current status because she had a dementia, and we perform it under the local anesthesia. So for the patient safety, we shift to our catheter implantation of the femoral common femoral vein. The tip is located over at the IVC. But surprisingly, the catheter survives about half a year, and the catheter has its post cuff with catheter dislodged due to the patient cell pull up. And so we have changed to the regular catheters. And however, the patient is had a multiple catheter failures episode that need a change per 1 to 2 weeks. So the nephrologist primary care that shift patient to the peritoneal dialysis. So in conclusion about our clinical experience about this drug coating technology, the heparin coating palindrome, is that it had a dedicated catheter design and very good surface coating to have the outstanding and reliable performance according to our clinical experience. And the manufacturer also provide a very good vena thread device to give better support during the over-wire exchange. But the Achilles heel of this catheter, it persists, is the infection. So further randomized control study to prove its clinical usage as the long-term chronic access, dialysis access is still warranted. I'm Dr. Xin from Chang'e Memorial Hospital. Thanks for your attention.
Thank you, Dr. Sim, for your talks on the drug coating technology. It seems that drug coating technology everywhere in vessel intervention device. We're going to have further discussion after next talk from Singapore.
For our next speaker, we're going to welcome Dr. Tae Kyang-hyung from Singapore, sharing about effectiveness of combination cutting balloon and drug-coated balloon angioplasty of AVF patency.
Good morning, everyone. Apologies for not being able to be personally present in Taipei to deliver this talk. I would like to congratulate the organizers for going forward with this meeting and using technology to enable the conference to go on. This morning, I would like to talk on using a combination of cutting balloon and drug-coated balloon for angioplasty of dialysis AVF stenosis. These are my disclosures. Of note is that the two trials that I'm going to talk about, the institution and concerto trials, were both partially funded by Boston Scientific. All of you are probably familiar with the KDOKI guidelines. Up to today, POBA is still the gold standard for the treatment of AVF stenosis. As you can see in these pictures, the results are often good, but the 6-month patency is often less than 50%. Fortunately, with repeated intervention, we are able to maintain the patency and function of this fistula, and 12-month secondary patency in excess of 80% is quite easily achievable. The main pathologic basis for development of stenosis is the neointimal hyperplasia. Numerous strategies have been described to address this entity, and here is one such example in an animal study where drug-eluting stent and bare matter stents were compared with the drug-eluting stent successfully inhibiting the neointimal response. Of course, in recent years, a drug-coated balloon angioplasty is the new favored method, and numerous randomized trials have already proven its efficacy when compared to POBA. Way back in 2014, we have done a randomized clinical trial comparing cutting versus high pressure balloon for the treatment of resistant AVF stenosis. In this trial, we found that the 6-month primary patency of cutting balloon is superior to high pressure balloon, and the difference is statistically significant, and the effect size is about 25%. 4 years later, our group conducted another randomized trial, this time comparing POBA with drug-eluting balloon. Again, we show that the drug-eluting balloon is superior to POBA at both the 6-month and 12-month time point, and they were statistically significant differences. The effect size is about 20%, so DCB is 20% superior to POBA. So we hypothesized that if we combine cutting balloon and drug-coated balloon, we may be able to get better patency. And the reason being, with a cutting balloon, we could reduce elastic recoil by disrupting the fibrotic stenosis. And as we know, recoil is a determinant of patency. Also, in cutting balloon, the disruption of the stenosis is controlled. Hence, it should incite less intimal response. And further, the cuts made by the blades of the cutting balloon potentially could improve drug delivery to the various layers of the vessel wall. So we went on to conduct 2 trials, the institution trial and the Concerto trial. So the acronym is generated using a software, and this is what it stands for. Essentially, the difference between the 2 trials is that for institutional trial, we are looking at the recurrent stenosis, whereas in the Concerto trial, we are looking at stenosis that were resistant to conventional angioplasty. We will show you the details in the later slides. So in institution trial, as I mentioned, we use a combination of cutting balloon and drug-eluting balloon for recurrent stenosis, and recurrent is defined as within 1 year of the last intervention. This is a prospective single-arm observational study, and I'll be presenting the interim analysis. We have already completed patient recruitment, a total of 44 patients, and 28 patients have already completed 12-month follow-up, and I'll be showing the data of these 28 patients. The primary and secondary outcomes are the standard ones that we see with fistula intervention. In the interest of time, I will be focusing only on primary patency of the target lesion. Of note, the patency assessment is based on clinical follow-up and not on imaging. The fistula is about 4 years old on average. The radiocephalic AVF forms the majority of the fistula, and most patients had interventions about 6 months before the index angioplasty. Target lesion length about 5 cm. Most of the lesion, as expected, is in the juxta anastomotic segment. The pre-treatment stenosis is severe, more than 70%, and most cases have a single lesion, but we do have some cases with more than 1 lesion, and in these cases, the most severe lesion will be chosen as the target lesion. The cutting balloons used are from 5 to 7 mm, and the drug-eluting balloons usually are oversized by 1 mm more. Most have good results with less than 30% residual stenosis, but we do have 8 patients with more than 30% residual due to elastic recoil. The target lesion patency is about 85% at 6 months and 66% at 12 months. This is one example, very typical juxta-anastomotic stenosis, treated with cutting balloon first, followed by the drug-coated balloon, and this is the result. This patient has not come back for repeat intervention, and it's already more than 12 months. This is another patient where the result is not as good. As you can see, the lesion is very long. Although the post cutting balloon and post drug-coated balloon angioplasty looks good, the patient returned about 7 months later due to decreased flow rates, and the repeat intervention angiogram shows restenosis of the treated segment. Next, we talk about the Concerto trial. As mentioned earlier, this trial is similar to the institution trial, but it involves resistant AVF stenosis. Again, it's a single-arm observational study. The sample size calculation was based on a 20% effect size, giving us 19 patients. So all these patients first underwent angioplasty with POBA up to 15 atmosphere inflation pressure, and they will only go on to the combination cutting balloon and drug-eluting balloon angioplasty if there is more than 30% residual stenosis. Similar set of outcomes as its institution trial, except that the cut-off time point is 6 months, and again patency assessment is based on clinical follow-up. Fairly similar to institution trial, about 4 years old, AVF age, predominantly radiocephalic fistula. Almost 80% have prior angioplasty. Lesion length is a bit shorter for this trial. The lesions are a bit more evenly distributed, and we have a bit more patients with more than one lesion, and again only the most severe lesion is chosen for the trial. This is one example from the trial of severe stenosis of BBT, AVF, after POVA, significant recoil, and went on to have cutting balloon followed by drug-coated balloon with good results. So for this trial, the residual stenosis is again quite good, and technical success was 18 out of 19. One patient had greater than 30% residual stenosis, and at the end of 6 months, none of the patients lost so-called target lesion patency. Only one patient returned for repeat intervention, and it was due to non-target lesion stenosis. So in essence, the 6-month primary target patency was 100% for this trial. So if we compare these two trials with our two earlier trials, we could see that it seems to show that by combining cutting balloon and drug-coated balloon, we have better results than cutting balloon alone or drug-coated balloon alone. Obviously, strictly speaking, we can't really compare the trials like that, but suffice to say that it is not worse than either. So to really be very sure, we need head-to-head trials by comparing cutting balloon or drug-coated balloon with the combination treatment. So in conclusion, our preliminary observations suggest that the combination of cutting balloon and drug-coated balloon is safe. We did not see any complication in both our trials. It is at least as effective as a cutting balloon or drug-coated balloon angioplasty alone. But our data seems to suggest it's better, and we feel that further studies are warranted, in particular randomized control trials, to confirm its efficacy and value in the treatment of AVF stenosis. Thank you very much for your attention.
Well, congratulations and thank you, Professor Tay, about the very impressive study on DCB plus cutting balloon. I'm sure our online panelists will have some comment on this. Please raise your hand if you have any opinion on that. Please.
Can I ask something very quickly? The cost factor is of a little concern here, isn't it? If you're using a cutting balloon and drug coating balloon, of course, would that has that been taken into consideration?
Yeah. So, panelists who want to echo on this, the cost effectiveness, or Professor Tay.
Yeah. Hi, can you hear me?
Yes.
Okay. Yes, cost is definitely a concern. I think similarly, when drug-coated balloon first came out for fistula intervention, cost is a concern. In fact, the randomized trial that we published, the POVA versus drug-coated balloon, although it was a positive trial, the patency advantage of drug-coated balloon over POVA was around 2 months, meaning it prolonged patency by about 2 months. We just recently completed a cost-effectiveness analysis based on that same data set of a randomized trial. And actually, for the first 2 years, it wasn't cost-effective. But there is a trend favoring that it might be cost-effective. And the reason it was cost-effective is that for the drug-coated balloon group, for some reason, the fistula abandonment was lower than the POVA group. And once fistula is abandoned, I think the costs go up significantly. So the short answer is actually the cost-benefit analysis, even if it's positive, is actually quite marginal based on our last randomized trial. So for this, which is why we think that to get more cost effectiveness of more value, we need to prolong the patency further. And one of the reasons we think that we could prolong that patency is to address the recoil issue. And the cutting balloon, unfortunately, it does help in some of the cases, but not all the cases. As you can see in the institution trial, we have almost 10%, despite cutting balloon, there is still significant residual stenosis. But those that we could overcome the recoil, it seems to lead to better patency. I guess this is similar in concept to the lower limb intervention, where now, vessel preparation is considered one of the key steps before we apply the drug-coated balloon. And if the vessel is prepared well, the patency would improve. But at what point the patency will translate to cost effectiveness, I think we still don't know. Unfortunately, for these dialysis patients, they are recurrent procedures. Even in the best, we are not able to prolong the patency indefinitely. So as long as they need to keep coming back, it is challenging to prove cost effectiveness, I think.
Yep, thank you. And other comments from our online panelists? Jackie?
Professor Tay, thank you very much for sharing the two very nice design studies, and it's encouraging preliminary results. I would like to ask your opinion in your experience of using the cutting balloon. How do you size the cutting balloon? And also, because I think there's always people concerned whether one should downsize the cutting balloon a little bit because of the nitinol microtome outside. And also, secondly, in my experience, to fully efface the stenosis, a lot of the time we have to go beyond the rated pressure putting on the balloon. And I would like to know your experience of usage of the cutting balloon. If you cannot get the lesion very nicely open at the rated pressure, would you go further up, or what would be your strategy?
Yeah, so for the cutting balloon sizing, usually, typically the patient would have a pole bar first, right? So from the pole bar, I would use it as a guide whether to use the cutting balloon the same size as the pole bar, or maybe slightly bigger than the pole bar. So that's point number one. Point number two is if the cutting balloon does not efface at burst pressure, I would not go beyond as the first option. What I'll do is I'll deflate and I'll rotate the cutting balloon so that the blades are now pointing in another part of the stenosis. And then I will inflate it again up to the burst pressure. If that doesn't work, I will deflate again. I would again rotate the blades. Oftentimes, by doing so, there is no need to go beyond the burst pressure. And quite often, sometimes by just keeping the balloon up for a little bit longer, it will cut. I have not really encountered a lesion that we can't cut. Sometimes after the cutting balloon, even if it fully effaced, on the angiogram, we could still see a residual stenosis. And quite commonly, we still put in a balloon, the pole bar balloon, to may need to oversize. If I need to oversize, I will oversize on the pole bar side rather than using a cutting balloon to touch up the lesion. Yeah, but of course there will be some that will recoil, not so much because the cutting balloon couldn't efface, but even with that happening, it still recoil. Yeah.
Thank you. Very promising result. So during the session, we have discussed on mobile detection, mobile flow detector, and we went through also the artificial intelligence technology in hemodialysis, and also drug coding technology plus cutting balloon usage in dialysis access. So I wonder if there is any last minute comment from our online commentators. So if not, I'm going to close the session, and I thank for all our online panelists and audience. Thank you.